Hey folks, so this is Jessica Flaherty at BU. So we are just going to wait for a few more folks to join us before we begin. I'm sitting here with James, and we are talking about records and other kinds of things, and you are welcome to do the same while you're waiting. So we're probably just going to take another 2 minutes or so, and we'll be back. Hi, everybody. We're going to get started. So welcome to our field safety chat. This is less a webinar, more a sort of ongoing conversation about strategies and tips for field safety. And so we're hoping that you all will offer up your own suggestions and questions, and we actually have a poll that we're going to launch somewhat in the middle of this, where we can get some feedback from y'all, and that's pretty much it. So I'm going to go over some of our basic rule-y things that we usually have. Sometimes I have trouble, guys. Sorry about that. Okay, here we are. So here's the instructions for this conference call. So it's being recorded, which is great because we want to be able to offer this to, or make it available for folks who are not necessarily able to join us today. And in order to hear this webinar, you should hopefully be hearing me now, but you can either call in or you could use, you could just plug in with your earphones and listen that way. We have muted you all, and we will work on unmuting you if we have questions or folks want to speak with us, but just to let you know, and this is really just to minimize the background noise. This is not because we don't want to hear from you, because we certainly do. So use the chat box to let us know that you have a question, and then we can just go ahead and unmute you. I am hoping that that will work, just because I don't have Marina here with me, and she's usually the one who is able to do all of the awesome tech stuff, but I will do my best to make sure that that works out the way we want it to. And then if you're having, if you have just sort of like a comment that you want folks to see, make sure that you sort of see if you're addressing it to everyone or to any individual or to us. So go ahead and do that. But then also, if you are having any technical difficulties and you want to just message me individually, you can go ahead and select me and let me know what kind of technical issues you're having, and we'll work on fixing it. That's me. So I'm your senior program manager here for the ETAP at the Center for Innovation in Social Work and Health, and I'm just going to be your moderator. James is the one bringing the brain power, and that's James. You all have either seen this wonderful picture of him before, or you've met him in person. And if you know that, then if you have met him in person, then you know that this does not do him justice, this picture. So James is going to give us a little bit of context and background about field safety. He is one of the experts in this area, and I'm going to let him take it away.
Great. Hello, thank you for joining me today for this webinar. I never realized how good looking I was until I saw that picture, so thank you for that, Jessica. So today we're going to be talking about outreach safety, which is a really important topic. And although I am familiar with our agency's safety outreach policies, you know, they vary from agency to agency, and they are really living documents that should be modified and altered according to the needs of both staff and patients. So I guess the initial question would be sort of why have a safety outreach plan or policy, written policy? The answer is pretty obvious. You know, you want to make sure that staff and the patients they serve are kept as safe as possible. The work that we're doing with our outreach is really sort of a very delicate mechanism. And, you know, our patients, our clients that we work with, you know, it really can take some time to build trust. And even patients that we've known for quite some time, you know, we're sort of a little bit under their magnifying glass. So anything we can do to really sort of help them feel safe by understanding the rules that govern the work that we do is really, really important. In the case of our written safety outreach, it was actually facilitated, I think it says in February 2013 in response to recommendations of the National Association of Social Workers Safety Task Force, which convened after the 2008 death of a social worker on a home visit. It's a little gruesome. And I have to imagine that there were guidelines in place before we sort of wrote this, what we consider a pretty comprehensive document. But I would imagine they were probably scattered in lots of different places. But you know, I think there was this unfortunate incident that sort of facilitated the creation of these guidelines. And then we sort of really looked at it from as many different angles as possible. Let's see, looking at my notes. Yeah, I mean, today, so we're just going to review our guidelines. Some of this may not necessarily be relevant to what you do or the work that, you know, the work you're doing or the services that you provide. But I guess the first question I want you to ask yourselves is, you know, does my agency have a written policy? Where does it live? Have I looked at it recently? Is there room for improvement? I find it so in reviewing this, and I have to admit, it's been a couple of years since I had actually looked at it, it's a good refresher for me to sort of understand why this document exists. And it actually, it sparked a number of thoughts. So you may access your agency's outreach safety plan, and it may actually sort of spark some thoughts for you, you know, maybe some ideas on how it could be improved or additions. And you can bring those forward to your supervisor. But I hope that your agencies do have one, and that you do get a chance to look at it. A lot of this might be common sense. Please forgive me if I'm just sort of stating the obvious, but we'll move on. Okay, the purpose. Creating and enforcing a written policy regarding outreach safety creates a climate of safety for employees and those that they serve. So not just for our benefit, but also for our patients. It's good to be able to discuss these things. The more safe we can help clients feel, the better. Protect staff allows them to convey to clients what services can be provided and under what circumstances. You may have people that you've worked with for many, many years, and some of these, you know, there are certain rules that there's wiggle room there, and there's other ones that really are hard and fast rules. So in reviewing some of these rules, we'll hit on both of those types of goals. And I want people in this webinar to chime up if I state something they feel differently, chime up, because I want to hear, you know, why you think there might be wiggle room within a certain rule or sort of guidance or suggestion. We hopefully, you know, the way that your teams and your agencies are constructed, There will be some discussion about outreach and outreach safety before you ever head out the door. You know, we want to make sure that people have those tools like good clinical supervision, sort of really discuss your patients beforehand and their needs so that you're aware of any sort of trouble spots and can, you know, not only anticipate them, but maybe have a chance to talk to your team about, you know, if you have concerns or questions, you know, what those might be.
My phone.
So angry. Okay. So outreach, what is it? According to this slide, it's defined as home visits, street visits, or any encounter with a patient that occurs in a non-clinic setting. Sometimes we have a respite up top in our building. The top 3 floors are respite. When I go up there to visit a patient who's inpatient, technically that's outreach. Or when I go to see a patient in the hospital, that's outreach. But I run into patients a lot on the streets, on the bus on the way to work or from work. It really is just sort of anything outside of, for our document, it says non-clinic settings. You may not work in a clinic. It's any place outside of the doors of your agency. It could be the sidewalk across the street or down the street. And we want to make sure that we're exercising safe practices by following the procedures listed below. Track whereabouts. You know, if we're working as a team, we want to know where people are at all times. And we never want a supervisor or an employee to say, hey, where's so-and-so? I haven't seen them in a while. I know that they something about going out to do outreach. We want to make sure that all of the outreach that's conducted on behalf of the agency sort of has buy-in from the entire team and people know where you are at all times. We want to make sure it's on calendars if you keep calendars, like team calendars. Definitely talking to your supervisor about any sort of outreach plans. I think the wording on this is a little strict. Any deviation from the schedule while workers are out of the office must be reported to the supervisor immediately by a method determined by the supervisor. We're a little bit more loosey-goosey on the team that I work on. You know, I will say to my supervisor, I'm going to pop out. Don't forget, I'm going to go this morning to see so-and-so. And then I'll text her saying, hey, I just left to go see so-and-so. So, you know, it's not, sometimes because of things like public transportation or weather or whatever, you're running behind or ahead of schedule. You know, a few minutes this way or that way is fine. And also it says workers are expected to start and end their day in the office with exceptions only as approved by the supervisor. Again, that is super strict, but I think what they're getting at is if you're going to visit someone last thing during the day, they want to make sure that if you're going to visit the client and then go home, that you visit the client and then you went home, not that something happened or they don't know where you are. Just, you know, develop a good working relationship with your supervisor. The thing about outreach is it's kind of like it is a very kind of fluid thing, and especially if you're working with a handful of high acuity patients or clients, you know, sometimes it's hard to sort of navigate everyone all at once. So things just kind of shift naturally as long as people are in communication. So this slide could be distilled down to the sentence, you know, develop and maintain excellent communication skills with team.
Forgive the typo. H&D is kind of a new word, but
we're inventing new words.
We're inventing new words.
That's what we're doing. Okay. So risk assessment. I guess, you know, what I'm hoping is that people are assigned to work with you or you're assigned to work with clients because their life circumstances are complex. And risk assessment should be part of any sort of like, you know, who is this person? What are they looking for from us? What can we provide? And sort of managing, you know, sometimes those are two very different things. So sort of managing how to provide services that will accomplish your goal, which is to engage the patient in care. I mean, that is a lengthy process. It's rare that you do one outreach visit and great, the person's connected, problem solved. It's always more complex, and there are reasons for that that go back to like trauma history and all that stuff, and even a person's just life circumstances or not having a phone. Just there's so many ways to sort of take the long road to really sort of connecting someone to care. It's a longer process, always worth it, and outreach is such an important part of it, because the message it's sending to the client is, they're willing to come to where I am. They really must care, and if you do that enough, people really do. They give you permission to prove by your actions that you care, and then we as outreach people are proving that we care. And so, a lot of the goals are met. Some maybe are more longer term goals, but that gets into sort of another part of the webinar. But we always want to sort of make sure that we're doing what we say we're going to do. And in order to do that, we really have to have a sense of who the person is and what their style is. So risk assessment is a way of sort of finding, through chart review, through talking to people that have worked with them at other agencies and at your agency, finding out sort of what their strengths are and what their weaknesses are and where their blind spots are, and just a little bit more about, and then you'll get a feel for who they are when you meet them face to face. And this comes up numerous times throughout this webinar, but our patients, we'll never know our patients thoroughly. We'll know what they choose to disclose to us. And that might be a little bit or a lot, or it might be different from what other people at other agencies are privy to. So just in terms of risk assessment, I think the really important thing is, risk around the neighborhood they live in, risk around the place that they stay, and sort of risk around sort of what their history is, and if there's any history of violence. So this is where it gets a little bit scary, and so I wanted to put in a caveat here that in the same way that drug manufacturers have to list any potential side effect that anyone taking the drug could ever experience, we want to have these levels of risk outlined ahead of time. It does not mean that you'll be working with many people that are sort of level 3 or level 4 in terms of risk factors. I've been in this field for over 20 years. I can't say that I've ever had anything bad happen during outreach, but it's good to be aware of things. So we'll be reviewing this. It's a little scary. I'm sorry about that. But it's Halloween, so let's scare ourselves. So level 1, which is considered the lowest level of risk, family history of suicide or homicide. And so next to these in parentheses are notes that I sort of wrote out that Jessica was kind enough to include. How would you even know that? I mean, and if a client is going to disclose, it's probably not going to be the first thing that's going to pop out of their mouth, and it probably shouldn't be the first thing that you ask them. If someone has a family history of suicide or homicide, that comes after sort of getting to know them a little bit, really develop that kind of relationship where you can say, we've never discussed your family or your background. Like, what is your family like? Though that information can be really, really useful, but that doesn't come, till a little bit down the road. Past history of impulsivity or disinhibition. Again, I'm always interested. So if someone does have a past history of impulsivity or disinhibition, why is it a past history? Why did it stop? Was there a period of time where you felt where there were circumstances that were driving this, or is it a past history that sometimes manifests itself intermittently? And is that the reason why someone has a hard time engaging in care? I mean, a lot of times, if you've done patient navigation or case management for a little bit, there's just this long list of nonverbal cues that you pick up on. And if someone has a history of impulsivity or disinhibition, you kind of notice it when you get in front of them. And it's this really nonverbal thing where you're like, okay, I'm getting more of an idea of who this person is. It's hard because I usually have an inner dialogue going with myself at the same time as I'm sort of disconnecting to observe from a very passive thing and I'm also sort of trying to be actively present. So you kind of have to split yourself into thirds to kind of do this job. And I'm usually, it's not like they're all happening at the same time. It's like I'm going back and forth between the three of them. Your style may be different. It might explain my current mania. Even just thinking about it is driving me crazy. But to sort of be present in the moment, but also sort of checking in with yourself regularly. That's how you notice things like impulsivity or disinhibition. So past history of intimate partner violence. And again, so this is in our guidelines, it's quoted from our guidelines, but it doesn't really sort of give us any information. So when I first read it, I thought, okay, so as a victim of DV, perpetrator, you know, I think that the only thing that really matters is in meeting with someone initially and sort of talking about barriers to care and barriers to housing and possibly barriers to employment, DV would be pretty high up there. It's pretty common in the population that we serve. So in discussing it with someone, you're treading a really fine line about, you know, you don't want to trigger someone, you don't want to re-traumatize someone, but having information about this, you know, will help you be more sensitive to what their needs are. I find sometimes that the way to address a topic that is, you know, super kind of heavy is to sort of be a little more clinical about how you ask it. And sort of like, you know, I'm going to ask you some questions about your past news just so I can sort of help create an environment where you feel as safe as possible. You know, do you have any history of DV? And they can answer yes or no. And I think if you sort of get more into the feelings of it and stuff, and also, I mean, just, you know, asking this of someone, you know, setting is everything, and asking in the wrong setting could just really be a relationship breaker. And also, you know, so the rules around us sort of traveling with a second person, it's always a good idea. And this would be a case where it's especially good. I mean, there's all this sort of dynamics between, you know, if it is someone who's a victim of sexual abuse and their abuser is male and you happen to be male and you're doing outreach, and just always sort of think about, try and anticipate this from as many different angles as possible. You know, at the very least, what you can say is just sort of a blanket statement about if you ever think of a way in which I can, you know, make you feel safer while I'm doing outreach, I want you to chime in and give me feedback on that, because, you know, your safety is really important to me. And if you need me to adjust or modify how I'm providing services. So you're talking about DV here, but you're also talking about sort of anything that makes the client you're trying to connect with feel unsafe. Like, give me your feedback. Like, I work for you and I can adjust how I do things to suit your style. So as long as you just let me know, because if I'm not doing it the way you want and you're not saying anything, then that would be a shame for both of us. And then also with DV, you know, it's so tricky with DV, and, you know, and this, you know, there are cases of perpetrators claiming to be victims, and just, it's just so complex that so in addition, like, this would be a clinical supervision discussion. It would be a good discussion with supervisor, and it'd be great if your staff, if you have behavioral health on staff, to say, look, I have someone, you know, I've looked through their notes, there's a lot of DV there, you know, as a behavioral health provider, what kind of tips can you give me on sort of how to best interact with this person? And you might get all sorts of good tips on body language and sort of, you know, verbal language, and just sort of setting kind of advice, you know, how to approach someone in a setting. Past history of drug activity in the home or outreach setting, again, how would you know? And so drug use in terms of risk assessment and risk factors comes up again and again. And I have to say that, so I sort of touched up the content over the weekend. I was thinking a lot about sort of drugs, in quotation marks, you know, and I really feel like it's different if it's marijuana versus crystal meth, or, you know, opiates versus stimulants. These guidelines are very sort of vague. And I have to say that if someone smokes a little weed in their home, I really have no problem with it and will not stop you from doing outreach. But again, you'd want to check with your supervisor and review your outreach plan, because, you know, it might be different for you guys. But past history of drug activity in the home or outreach setting, we would have no way of knowing that. But it you know, much like DV, this comes up as a potential barrier for employment or housing. If there's other stuff attached to it, and with sort of long, like, chronic drug users, there's usually other stuff attached to it. And then past history of self-mutilation. We have the luxury of working in a health center, so I can really review all the notes. If someone's been in care for 5 years, I can look through those notes and really, and especially the behavioral health ones, to sort of see if there's a history of self-mutilation. You may not have that luxury, but these are the things that should not prevent you from outreach, but are a great springboard for referrals to behavioral health and other resources in your community. So no behavior exists in a vacuum. People do things for reasons, even if they're not clearly aware of what those reasons are. When I hear self-mutilation or cutting or something like that, I just think, you know, that person must have reached a level of frustration or just sort of stress in their life that was their response to it. So what we're trying to do is we're trying to recognize the level of stress and find something comparable that doesn't involve self-mutilation. And those tools do exist. So a lot of this, a lot of this really involves you guys, the patient navigators or case managers, being willing to say, being familiar with resources in your community, or being willing to say, you know what, I don't know the answer to that, but I'm going to do some research right now on my work phone where I can access the internet. Let's dig up some resources for you, because this is not okay for you. Okay, so now we moved on to level 2 risk factors. These are slightly more risky. And again, as I said earlier, level 1 and 2 are probably the ones, the population that you'll be working with exclusively. Must trigger a safety plan review with supervisor and visitation only in teams of 2. Now I know that so I pulled this last week. I know since this was written, we have sort of modified our plan in that outreach must always have 2 people. And that could be 2 case managers, it could be a case manager and nurse, it could be a case manager, patient navigator, it could be a case manager and someone from another agency. So there's lots of different ways to sort of, actually doing outreach with people from other agencies is a great way to do warm handoffs, or to sort of get more buy-in from the patient. If it's someone that this, patient has worked with, and knows well, their stamp of approval will actually carry some weight. So these are the level 2 risk factors, a little more risky than level 1, active drug or gang activity in the family or neighborhood. I was thinking about this one, like, I have been, so when patients talk about feeling unsafe in their neighborhood, I do sometimes go on, the online police blotters for their neighborhoods, and I look and see what kind of crimes are happening in their neighborhood. And sometimes those give a little bit of the picture, sometimes not. I don't know if people have ever accessed these, but anytime someone calls the police, and sometimes especially in small towns, those crime blotters can be very, very humorous. So I've been known to read them for recreational value, but in this case where it's they're reporting like drug or gang activity, like look it up, or you can look it up with the client. Sort of say, let's look online and see, because it might be that there's a lot of stuff that's not getting reported. As a matter of fact, especially going back to like DV and stuff like this, and drug and gang activity, a lot of it does not get reported, and we know that. History of restraining orders in the distant past, either obtained by the patient or placed on the patient. So again, whether it was recently or in the past, clearly something's going on there, and you want to know the nature of the restraining order. If a client had to file a restraining order because her ex was stalking her, unfortunately that's pretty commonplace. If the person in the past has had multiple restraining orders filed against them, I gotta wonder, like, so as a case manager, everything is like context and subtext. What was going on or is going on that necessitates that, and how does it play into their ability to engage in care or in housing services or in employment? Some types of information are publicly accessible, others are not. I on some occasions, because clients have said, I really like to look at my criminal record can we pull a copy? Will you look at it together with me? I've done that with patients on a couple different occasions. It's always a good idea because you can review with them. I mean, especially if you're working with them on housing and stuff. You want to know what other people are going to see, and maybe it's been a while since you looked at it. And it's actually, if it's been a while since there's been any sort of criminal activity, it's great to be able to say to people, this was you a long time ago, and the you of today is very, very different. And I want to take a minute and sort of reflect on how far you've come, because it sounds like at one point you're having a lot of problems, and the criminal system has not heard a peep out of you in 7 years, and right on. And then also, is the criminal record sealable? In Massachusetts it is, and there are new laws that were passed to make it even more favorable for the client. So if at all possible, seal. But I almost, in reviewing things like restraining orders that are in the past, if the person really has put in some hard work, maybe engaged with behavioral health, if they're the person the restraining order is placed against, if they put in work to sort of correct what was causing the problem, you have to really acknowledge it, and it's a great way to build a better relationship with the individual by talking about, these are not small things, these are huge things. So props at every turn if the person's been doing the work. So level 2 risk factor, known person in the home with a history of criminal violent offense, including sex offense. So as I was saying, sex offenders, their information publicly available. I go online and look at it all the time because I want to see what other people are seeing. A lot of other things are not generally available, and it's more of a process. I mean, I think, at the heart of this, and the reason outreach is important is, we really are messaging to the person they are an individual, and that we want to get to know who they are. The problem with sort of all the stuff like restraining orders and, sex offender statuses, people are reduced to police reports and sort of data and sort of accounts and reports. But that doesn't tell us who the person is. And in order to really build a good relationship, you have to get to understand who the person really is. Sometimes, trying to think of a way to say this, because patients let us know who they are, what they want us to know about them. Who they are might be very different in your office than it is out on the streets. And I would urge people to sort of really, people are and should be multidimensional. So for patients, who don't get much approval or sort of validation, for them to want our approval means they're probably showing us part of who they are. But I've seen patients who are just so lovely and pleasant, who are in survival mode out on the streets, and I see a different side of them. Assume there's another side to all of your clients. That's normal, and actually it's healthy. What's important is that they sort of, I like it when patients come into my office and sort of are on their best behavior. But I also say to patients that when they're struggling is when I need to see them even more. So even if they're not feeling well, especially when they're not feeling well or not at their best, is when I need them to come in more or contact me more urgently. Because when things are fine, then I don't have to worry as much. But when a patient is in crisis, it can lead, it's like a domino effect, it can lead to a lot of other things that can cause, additional barriers to housing and employment, and we're looking to reduce barriers. So I think our clients want to know that we're not going to judge them for their history of criminal violent offenses or their, sex offender status. There's just so much stigma attached to those labels and those behaviors. And a lot of them are sort of, we have more than a handful of patients that are mislabeled as sex offenders. So you probably know this already, so I'm preaching to the choir. History of suicide attempt or violence directed at others in the distant past, or history of suicidal or homicidal gestures. Again, if you know someone has this history, bless you, and you want to help them feel as safe as possible, and you want to feel as safe. So all of this is sort of, all of this gets preempted by the fact that if your radar tells you something, listen to it. So if you've met a patient once, they seem lovely, but you've read they have a history of suicide attempts or violence directed at others in the distant past, and your gut tells you, you know what, let's meet at the coffee shop in a public setting. I'll buy you a coffee. We don't even have to talk about anything else. We can just sip coffee and talk about last night's Red Sox win. We just talk about how we won the World Series, right? We won the World Series. We won the World Series. So I'm not bragging today. I had 2 goals for today's webinar: to remind everyone on this call that we won the World Series, and to get the song Baby Shark stuck in your head. So hopefully I've done both of those by now. Lastly, on the level 2 risk factors, unexpected or unreported strangers in the home. I have been in this situation before. And sometimes the client may say, oh yeah, no, it's not a big deal. I mean, I just have this person, like this person's crashing with me. It's a good springboard for a discussion afterwards about, well, you know, when I meet with you, it's sort of just meeting with you. I don't know what this other person may or may not know about you. And it's kind of awkward to have to explain what we're doing or why we're doing it, and we don't know who this person is. So unexpected or unreported strangers, it's not that it induces necessarily a sense of danger or menace, although I've been in 1 or 2 situations where I visited someone, there was a person there I didn't know, and I didn't feel comfortable, and I did sort of I did leave and then follow up. But generally, you know, we're there to do one-on-one work with a client, so extra people, it's kind of not okay. Okay, so now we're coming into an area where I hope you might not be working with a lot of these folks or any high risk. Again, they're calling for a safety plan review with supervisor. Level 3 risk factors. Let me get to it. Oh, it's so fun. Yeah, actually, we're going to do both. So many of the folks that we're talking about, they're level 3. So level 1, low risk. Level 2, a little bit of risk. Level 3, higher risk. Many of these folks might be considered deal breakers. So let's find out whether you think the following are deal breakers, as in I should not be working with this person. I love technology. All right, so the poll is up. 19 lovely folks on this call. And if you want, I can read these, or you want me to read them? I'll read them. Okay, some of these no-brainers, some. Okay, so no cell phone reception at the place of outreach or home visit. Ability to communicate with teams, obviously crucial, but you're going to visit someone, you don't know them that well, there's no cell phone reception, you have no way to communicate with your team. Number 2, past history of suicide attempts or current suicidal preoccupation with plan or intent, but able to contract for, is that able or unable? I think it's unable. I think that's a typo.
Unable.
Unable. So someone suicidal and unable to contract for safety. Would you work with a person or not? History of violence directed at others or property within the past year, or they're currently homicidal. Persistent self-destructive or aggressive behavior. Unable or unwilling to contract for safety. Persons hallucinating. Instructing harm to self or others, so someone's not reality-based. Active or recent intimate partner violence. Active or recent restraining orders, either obtained by the patient or placed upon the patient. Active drug activities in the home. Patient is under the influence of drugs. Oh, we got good voting here. So I wonder, can this, let's see. This is why, so I understand nothing about technology. I'd love to hear about, I'd love to hear from people, like sort of what the, if there's anyone here where it's like, yeah, I could totally work with this person, no problem.
So you're asking folks to say if there are any of these that they feel like they wouldn't have a problem working with at all.
Yeah.
Okay, so if you all want to answer that question, just type in the chat box, like, hey, I have an answer, and we can unmute you. It could be that people are not feeling
votey.
votey.
I'll put on some baby shark. More music while you poll. So that's the thing. Oh boy. I was instructed to turn that noise off, but I thought it would help you feel more comfortable voting. Anyhow, every 3-year-old in the universe is listening to that song right now.
Should we end the polling?
Let's end the polling.
All right.
And we'll see what people. So are there any where it was clear everyone voted the same way? Does this mean 3 yes, 7 no? Share top results.
Well, it looks like we've got folks who are saying if there's active drug activity in the home or under the influence of drugs, seems to be a pretty high response. Hallucinations and instructing to harm self or others. Let's see, we've got persistent self-destructive or aggressive behavior and no cell phone reception. So those are all pretty much equal.
So is that 4 yes, 7 no? Is that how that, what's the 4-7?
Among those voting, yes.
Okay.
So there were 7 total.
Okay. So this is how people who said, I have no cell phone reception, but I'm fine doing outreach. It's not a problem for me. Mm-hmm. Okay.
Good.
Yeah. Very interesting. I am interested. So for some of these questions, like it's kind of interesting, as these are all sort of level 3 high-risk individuals, for people in the poll who said, yeah, I totally work with that person, no problem. I'd like to hear more, if people feel like sharing or typing something into the box, or, you know, we can unmute you. Be more interested with some of these. I mean, if someone is actively homicidal, I mean, there's certain things where it's just, that is a no-brainer. Other ones where it's a little bit, you know, a little more squishy. So we can review the level 3 risk factors, but if people want to chime in, feel free, because I'd be interested in your input. Move on to the next slide. All right.
Oh, hold on.
All right. So level, oh no, I think we missed the level 3 ones. Oh no, we did actually. No, I mean.
Those were all the ones.
They are, but I want to make a few points about it. So no cell phone reception. Our building actually has really poor cell phone reception. So so there are places like older buildings that are lead lined, or for whatever reason, it's hard to make calls. Sometimes you have to adjust the outreach plan to work around the issue, and that could be maybe having the person meet you at a place where there is cell phone reception. I mean, if you're trying to connect someone with medical care, you know, if they say, oh, I missed my last doctor's appointment, to be able to say, like, you know, well, that's why I'm here. Let's call the clinic right now. We'll reschedule the appointment together. I'll write it down for you. And if you don't have cell phone reception, I mean, in addition to not being able to get a hold of someone if there's an emergency, there's sort of that whole connection piece that's really important. And then with past history of suicide attempt or current suicidal ideation, I guess the point here is that we are not mental health clinicians. We are patient navigators and case managers. It's actually, so early on in my career, I thought, oh, it's not a good idea to provide mental health support. And then I realized it's actually dangerous. So because we're not licensed clinicians, clients may feel more comfortable talking to you instead of a therapist, but there's reasons therapists are sort of licensed and credentialed. So any sort of like, if someone really is in sort of emotional turmoil, their connection to housing or employment is not the important part. The important part is addressing the mental health need. So, you know, really, really connecting them to a team if they are currently suicidal. History of violence directed at others or property within the past year. The sad reality is that we have 1 or 2 patients who really are that way, who are in and out of jail. And I hope I don't offend anyone. We have only 1 or 2 patients who have a hard time functioning within society, and places like prison or jail are some of the only places that they feel safe because it allows them structure. They have access to meds. You know, if they've been institutionalized for so long that that's the only setting that makes sense to them, then maybe that's where they need to be. I wish Patsy were here to join in, because that's currently part of her job, helping people transition out of corrections into society. One partner that would be really invaluable for outreach would be anyone that can help people sort of reintegrate if you have those types of agencies in the cities in which you live. You know, the one about persistent self-destructive or aggressive behavior. I mean, I have patients that are aggressive, but not so aggressive I can't work with them, or not so aggressive they can't be redirected. I think when it's sort of they're not in control of their behavior or their aggressiveness or their self-destructiveness, that's the issue, not the behavior itself, but sort of the inability to be redirected. Unable or unwilling to contract for safety. You know, again, before you start working with someone, find out what behavioral health resources are available at your agency, but also in the community. In Boston, we have something called the BEST team, which is Emergency Behavioral Health Services. We call them pretty regularly when people are just at their wits' end and there's active homicidal or suicidal ideation. So the question is, what resources like this exist in your neighborhood, in your community? Restraining orders. That is a great sometimes we have patients who are experiencing domestic violence who haven't filed a restraining order, and being able to say, you know, let's do that together. Let's go to the police station together. Let's talk a little bit about it. If it's something you want to do, I can help you with that. Great way of building rapport. And then patients under the influence of drugs. You know, at a certain point, some patients are too high to really, can't really get much done in terms of case management. Maybe there's other services that they need. But I think coming at someone with a service plan when they're high and not able to sort of process it is not fair to the individual. So really sort of doing an assessment about what they're capable of. And then there was a last one, patient states workers not welcome in the home. We can always work around that. But is it ever a great idea to meet with a client in the home, you know, as an initial meeting or even an early on meeting? Maybe that's something. It just takes so much trust for someone to let you into their environment, and especially if it's a home setting, whether they're doubled up or unstably housed or what any of the other criteria for this initiative, you know, taking a minute to really think about what it means for someone to welcome you into their home, thinking about why that might make them nervous and sort of what an act of bravery it is, even after you've built a rapport with a person, it's their home. So, you know, public settings are great in that you can take them out to McDonald's, have a bite to eat, chat, and then maybe take a walk to talk about some of the more sensitive stuff, and you don't run the risk of anyone feeling violated or that you're intruding into a home setting. Last risk level, level 4, you probably read this while I was yammering, but this would be under the, you know, absolutely no home visits should occur. In reviewing this over the weekend, I was actually thinking like, and what are even in some cases, clinic visits. Unsecured weapons in the home or on the person. Again, how would you know? Anything could be a weapon. We have plenty of patients who are homeless who carry weapons, even if it's a screwdriver or nail clippers. You know, people need to defend themselves when they are street homeless or in shelter, and I think you can definitely have a discussion with people. Like, just sort of setting some ground rules and saying early on, you know, my expectation is that when we meet, you're not going to have any weapons on you. I hope you understand why this is. And, you know, if you do carry a weapon, let's come up with a plan for you to sort of stash it somewhere so that you can retrieve it. And by weapon, I assume we're not talking about something like an unregistered gun or something. We're talking about things like screwdrivers, nail clippers, etc. It's a really delicate subject.
So I'm going to just jump in for 1 second. I'm sorry, just around time. I'm
Yes.
sorry, James. So we're going to have this room available to us. This room is in not the physical room, but the Zoom room. So I just wanted to make sure that we hit a few of the other slides just before before we
Absolutely.
Run out of time.
Sure.
So these are just moving on from the risk assessment slide.
We can send you these slides so you can review them.
Mm-hmm.
And if you have any questions, I mean, email me, call me, any of that, happy to discuss.
So we're saying also that as part of the policy, training should definitely be a huge part of it. And in fact, that you might want, if your agency doesn't already have a policy that includes mandatory training, maybe even annually, that we might want to think about doing something like that.
Yeah.
Mm-hmm.
Yep.
So as far as dress and valuables goes,
yep.
Wanting to avoid things that might potentially be a choking hazard or might be used to choke somebody.
Yes.
Leaving your valuables at home, leaving vehicles locked. Don't use any headphones or those little those earbuds that are wireless where you're talking to people on the phone.
Yeah.
Making sure you leave your ID on, right? Really important.
Yeah. So we have this sort of tearaway lanyards. Again, in my 20 plus years, I've never had an incident with someone grabbing my lanyard, but this is something that you just want to just be aware of so you can avoid anything ever happening to you. This last one, dress discreetly, non-scriptly, I added that. That's not part of our policy. That is me talking nonsense, but really, you know, it's pretty common sense. If there's anything here that does not make sense to people, chime in either in the message. Do we have this until half past, or do we need to finish up on the hour?
We need to finish up on the hour.
On the hour, okay.
Sorry.
No, it's fine. I can whiz through these. Teams of two. I think we reviewed why, and just coordinating. Just stick close to each other, discuss the plan before heading in, sort of gauge the room when you step into it with the client and sort of get a feel for what's going on. Breakaway lanyards, personal safety alarms, we have those. To be honest, sometimes I leave it at home, I forget about it. I'm bad that way. Pre-planning, and then just sort of planning, you know, just sort of positioning yourself near the doorway if possible, and sort of, you know, setting stuff up so that you can have a coworker call you to check in midway through the meeting. That could give you an easy out, like, oh, I have an emergency at the clinic, I have to split, please excuse me, I will come back.
Also, just you can see that James actually included a website for you to check out personal safety alarms and see what that's all about, just for those of you who may not know what that is, which I'm one of those people, so I'm going to take a look at what those are. And then in general, you've got some general safety tips. Yep.
Use universal precautions, meaning that every person in every environment is considered potentially dangerous. Be friendly and kind, but stay focused on the work that needs to be done, and, you know, again, identify and restate goals. This is from the agency document. It's a professional relationship, not a friendship. You know, and so the question is, do you correct someone who calls you their friend? I think it comes up in one of the case studies. You know, our perception of who we are in the patient's life might be different than theirs. Trust your instincts, trust your guts, and always, you know, set up as much as you can ahead of time, anticipate barriers, problems, issues, stay alert, know what behaviors provoke you, and ways to respond to those behaviors without placing yourself in danger. I mean, so in having these initial discussions with patients or clients, I always remind them of things like there are certain things that will absolutely get you barred from care with us, if you strike a staff member. There's certain things we have zero tolerance around. Many other things we can work with you on. There's certain things that are just absolutely not tolerated. Keep your hands free. Car keys in your pocket or hand. This one, I'm not sure if I understood it completely, but you definitely do want to have them handy. They might be around your neck, perhaps on your lanyard. And then sort of contracting with clients around appropriate and inappropriate behaviors, establishing clear boundaries. And again, there's a sort of gentle way to do this and sort of a mean or inappropriate way to do this. If a particular individual is not sort of known to sort of understand subtlety, sometimes you coming off as mean might not read that way to the client. So, there are times when I feel like I'm being like really mean and really direct, and I'm not. I'm just being very clear about what it is that I need from the client in that moment. Money is always a big thing, sort of, helping clients manage their money or connect with a payee service. Again, this comes back to community resources. And this thing about there's certain things just not allowed. We can never borrow, save, give, use, or exchange money or other valuables, including ATM or EBT cards. That's a food stamp card with patients. That is around boundaries and just being very clear about what we are and aren't able to do. Safety during a visit. Remember, you're in their home. If you come up to the door and there is just craziness behind the door, immediately leave. Or even if even unusual smells might sort of trigger a different reaction. Be aware of exits in case of emergency. Maintain clear access to an exit at all times. Again, if there's a stranger or unapproved visitor, that's when you need to sort of like figure out, what's up with this and whether you should leave. Sometimes it is someone from another agency. I've experienced this many times, and you can team up with them. But again, you don't know what they know about the individual, so you don't want to be blabbing the person's business. Really, it's about discretion and sort of erring on the side of caution when disclosing anything about a patient or their circumstances. If you perceive the presence of drugs or paraphernalia, or in some cases, as I've had happen, if there's a lot of hypodermics all around the room, maybe not a great environment. But, it means you can leave, but you could say, I got to go, but do you have time to grab a quick cup of coffee with me? Like, let's get something to eat. Have you eaten today? Be aware of personal space. Again, just really reading those nonverbal cues about whether you're standing too close to the person or too far. You don't want them to think you're afraid of them or nervous about interacting. Avoid sitting on a patient's bed. That is in the actual written thing. I did not add that. I'm wondering why that particularly. And why?
If I had a guess, I would say the hypodermic needle, right? Maybe in occupational exposure to somebody's hypodermic needle that might be in their bed.
Yeah.
There's also any number of contact STIs, right? So there could be an infection of.
But who would ever sit on someone's bed during a home visit? It just seems wacky to me. It's not, I would rather kneel and at eye level and maintain eye contact than sit on a bed. And it's fine to be like, I have a bad back, I can't sit for too long, I'm going to kneel, if that's okay. Whatever you can do to avoid shaming the person or saying, making it seem as though there's reasons why we can't, but we don't want them to think the worst. You say, I've got a bad back, I'm going to kneel. Be aware of surroundings, both as you enter the neighborhood, while you're in the apartment, and as you're leaving. Don't get on the phone. Yeah, and this thing about discussing things in an elevator or a lobby or on the block where someone lives. Like, I've actually had other service providers from other agencies disclose information about people. I'm like, I know that person. I'm thinking to myself, I know that person. And how uncool it is to sort of be talking someone else's business. Lock your car doors as soon as you get in. Right? And then there's weather. Maybe you live in a sunny place. We live in a place with lots of seasons. And not only can sometimes weather be a barrier to a home visit in that we're having a nor'easter, but I find that, seasonally our patient's energy level varies. So if I call someone, it's a rainy day, and they're like, you know what, it's rainy, I'm under the covers, I feel safe and secure. I just want to zone out. Can we schedule for another day? Fine, no problem. Sometimes I feel that way too. Keeping a list of emergency contacts for each worker that does outreach. Again, people nowadays have 800 different phones, and people change their phones every 2 minutes. So making sure you keep those lists, but also update them. The safety plan, and reviewing the safety plan, and updating the safety plan, and modifying the safety plan. Always providing accompaniment whenever possible. Again, the exceptions would be, I'm meeting the person right in the hospital. It's a captive audience, they're inpatient, I don't need a second person. Or, I'm meeting them at another agency, that case manager can't join me, but we're in the lobby, we're surrounded by staff of this other agency where the person accesses services. So it's really, I don't need another person. But for the most part, it's always good to have another along. Address the threat of violence or the aftermath of violence by attending to the needs of the worker, coworkers, or affected patients. Presenting an open environment, really debriefing with, if it's something that happened to the client, debriefing with them, debriefing with your team, debriefing with a lot of it involves your perception of events might vary from someone that was there with you, or might vary from someone who has worked with this client for a long time. So debriefing, although it sounds like a lot of time, it's actually an investment in building that relationship.
And James, we have a lot of supervisors who I just did a quick look who are on the call as well. So just that this is a really important part for folks who are supervising people who might be doing outreach, just things to have in place. So it's not just sort of all on the agency to have a policy or on the individual outreach worker to know the policy, but that also supervisors can help support as well, right? Absolutely, because you're going to see themes in outreach. You're going to see things. Each instance is unique, but there are sort of themes, and to sort of really explore that with your supervisor really, really helps. And then in terms of expectations for supervisors, you want to sort of be tracking the interactions, the details of the interactions, direct quotations from the person if you can. That really gives a flavor of what the interaction was like. And then if there's any sort of serious incidents, definitely communicate with the chief operating officer. We have an attorney who is our compliance officer that we go to with a lot of questions. And again, coming back to these zero tolerance issues, I've never had a patient do something during outreach that was cause for dismissal from services with us, but it could happen. We just don't want to wait until it does happen to sort of be aware of what the procedure is. So we're doing case studies. So here we are at 2:04. So I'm not certain that we're going to be able to have folks stick around. People are starting to drop off the call because we have an hour with them. But just something that I would make a recommendation on. So first of all, these are brilliant case studies. Thank you. There's 2 of them. I would actually recommend, so we're going to send these, we're going to send a recording of the webinar out, but also we'll send the slides as well. I would recommend that folks bring this to a staff meeting, just a project staff meeting to talk about these 2 case studies and start like sort of exploring and unpacking some of these things and answering the question, what would you do? And so, and then also make sure that you sort of write down any questions that you have, anything around, I'm not really sure what I would do, or I'm not sure what the policy is, or I'm not sure how I would be supported in that. And then try and find out how you can get answers to those questions. And these case studies are not only what would you do, but in what, like it's about prioritizing need and about prioritizing sort of your role as a case manager. So there's a lot of red herrings in these case studies. Red herrings are the kind that baby sharks like to eat. So these seem very simple on the surface, but they're not, and they're both things I have experienced. So they're drawn from real life. They're drawn from experience. Look those over and get back to me, because these are rich case studies for discussion, amongst team members. And we don't necessarily have time for Q&A, though. What I would do is keep the conference line open in case folks do want to ask James any questions. We want to just sort of respect the time if people need to jump off, but we'll stay on the line and answer any questions that might have come up in the moment. But also, you can feel free to contact James directly as a content expert here. He is volunteering. He's nodding his head yes. He is volunteering to have you send any and all questions his way if you like. And if you, for some reason, want to ask me the question first and you want me to send it over to James, I can do that too because he's right across the street from me.
And also, if you're going to be at the Ryan White conference, the upcoming one, and I haven't met you, come up and introduce yourself. You have my lovely picture that you've seen, so you know what I look like. I'm dressed exactly the same.
And just so everyone is aware, we do have an upcoming webinar. Our very next technical assistance webinar is going to be on stages of change. It's on December 18th. And we look forward to seeing you then. And then thank you all so much.
Thank you.
Will these slides be emailed to the group with a question? And yes, indeed, they will be. We are going to email them out to everyone. So I'm just going to leave up the questions. And just, again, if folks need to jump off, that's no problem. But if you wanted to, we'll stick around for a little bit and keep the line open if folks have any additional questions. And thank you all for joining us.
Thank you.